Dear viewers, in this video, I am going to talk about the airway management in emergency, particularly in ED and ICU settings. Now, this is a topic which is primarily aimed at the learners or the beginners in critical care, but its importance is, is there in all stages of career, and periodic revision is necessary so that nothing is missed out. Because even if small things get missed during the airway management, it leaves a very big impact on the patient in terms of morbidity, if not mortality. So, the airway management in emergency is something which is always revised time and again, and one needs to keep updated about the latest advancements or the latest modifications that different societies, the different guidelines post from time to time. Let us start with a case where a 40-year-old male of road traffic accident with fractured mandible and traumatic brain injury presents to the ER. The vitals reveal a respiratory rate of 40 per minute, heart rate of 120, blood pressure of 100 by 60, and a saturation of 90% on room air. On examination, the patient appears delirious with obtunded reflexes, although clinically normal abdomen, but chest showing reduced bilateral air entry. On lung ultrasound, there is pneumothorax on the right side with multiple B lines, although there is no ascites on EFAST. So after insertion of chest tube on the right side and ensuring that there is movement of the air column, patient is put on oxygen through the ventimask at 6 liters per minute, along with antibiotics, analgesics, and other necessary treatments, only to witness after 15 minutes that SpO2 drops down to 80%, the respiratory rate is high, and the BP has started falling. Now, how will you manage the airway? Now, this is an emergency situation because this patient has fracture of the mandible and TBI besides pneumothorax. So, patient can pose a difficult airway. And also considering the situation that patients has a falling SpO2 with a falling blood pressure, it requires emergency attention and emergency intubation. So, in all such cases, it is important to follow the universal airway algorithm. The first step is to assess whether the patient is unconscious or whether there is any foreseeable imminent cardiac arrest. If the answer is yes, the patient shifts to crash airway algorithm. If the answer is no, the patient needs to be checked for whether there is any likelihood of difficult airway. If the answer is yes to the likelihood of difficult airway, the patient moves towards difficult airway algorithm. If the answer is no, the patient moves towards rapid sequence intubation. Rapid sequence intubation, we all know, it is the application of cricoid pressure at the time of induction, and after that, there is no positive pressure ventilation, there is no administration of relaxants. There is administration of relaxation, but there is no positive pressure ventilation. Now, after rapid sequence intubation, there can be failure. There can be failure after difficult airway algorithm, as also after crash airway algorithm. So, whenever there is failure, they cannot succeed, they shift to the failed airway algorithm. Now, this failed airway algorithm will also depend on the availability of the gadgets, the experience of the intubator, and so on, and it has to be devised locally. But the important thing to note is that there are certain gadgets which are essential, should be available at all locations where such a situation can arise. And also, there should be at least one or two operators who are well versed with all the different gadgets. So, the first question also arises that what is then a difficult airway? Since we have to go and assess for the difficult airway, once we know that the patient there is no imminent cardiac arrest or patient is not unconscious. So in the emergency setting or the ICU setting, there is no standardized definitions for difficult airway. It is the same difficult airway definition which follows from anesthesia practice, that is crept along. But the difficult airway is generally divided in emergencies department settings into certain dimensions, which includes difficult laryngoscopy, difficult bag mask ventilation, difficult extraglottic device insertion, and difficult cricothyroidotomy. All are important, no doubt, but of particular importance is the difficult laryngoscopy. In laryngoscopy, difficult laryngoscopy, we are all aware that Cormack-Lehan grade is the most widely used system. Especially all my friends who are from anesthesiology are well versed to categorize the degree of visualization of the larynx with laryngoscopy. And the CL grades of 3 and 4 are the ones which most highly correlate with failed or difficult intubations. Another simple clinical test is the upper lip bite test to test whether the lower incisors can bite the upper lip. If the lower incisors cannot bite the upper lip at all, then it is taken as class 3, where the likelihood of difficult laryngoscopy is very high. Now, for predicting difficult laryngoscopy of the various acronyms or the mnemonics that are available, the one which is very popular and very useful is the lemon. Lemon has 5 alphabets. The first alphabet L stands for look externally, where you look at the patient externally for characteristics that are known to cause difficult laryngoscopy, like short neck, double chin, etc. Difficult laryngoscopy, intubation, or ventilation. And it goes, one knows that these are the various factors. The next alphabet is E, which means evaluate the 3-3-2 rule. 3-3-2 rule has 3 ingredients. The first 3 is inter-incisor distance. It should be at least patient's 3 finger breadths. One has to note that it is patient's fingers and not the intubator's fingers. Hyoid mental distance should be at least patient's 3 finger breadths. Here also 3. But the third segment, which is the thyroid to floor of mouth distance, that should be at least patient's 2 finger breadths. So that is why it is called the 3-3-2 rule. So the next alphabet is M. M is Mallampatti. Mallampatti again is well known to all the anesthesiologists. The hypopharynx views are graded by this classification, where class 1 is visualization of soft palate, uvula, fosses, and pillars. Class 2 means visibility of soft palate, uvula, and fosses only. Class 3, where soft palated, the base of the uvula is visible. And in class 4, where only the hard palate is visible. The next alphabet is O. O stands for obstruction, which implies any condition that can cause an obstruction of the airway, making laryngoscopy and ventilation difficult. Conditions like epiglottitis, tumors, abscesses, and trauma. And the last alphabet N stands for neck mobility, which implies patients in hard collar neck immobilization who have no neck movements, and therefore they are harder to intubate. Of importance is to note that this lemon criteria should be used in the resuscitation room, and although the original criteria included Mallampatti score, the modified lemon criteria has excluded this score, and this modified lemon criteria excluding the score has also been validated externally, and it is concise, and the absence of any items in the criteria indicates the absence of difficulty of difficult laryngoscopy with a high sensitivity and negative predictive value. Once assessed for the difficult laryngoscopy, next is preparation of the emergency airway management. And here also the important acronym is STOP-MATE, which can be used as a mnemonic, where S stands for suction, T stands for tools for intubation, which includes laryngoscope, blades, handles, etc. O for oxygen, P for positioning. It should be noted that always head extended and neck flexed at the atlanto-occipital joint may not be the best position for intubation. M stands for monitors, which includes ECG, pulse oximetry, blood pressure, EtCO2, esophageal detectors, if available. A stands for assistant, because in a difficult airway, one should keep an assistant because of uncertainties. And along with ambu bag with face mask, airway devices, different sized endotracheal tubes with stillets, etc. I stands for intravenous access, and D stands for drugs for pre-treatment induction neuromuscular blockade, and also any adjuncts if there are. So sufficient preparation in the emergency airway management includes identifying the difficult airway, developing an airway management plan, and assembling all necessary personnel, equipment, and medications. Also, this includes the rescue methods for failed intubations because one needs to be versed with those skills of rescue intubations. The first step is pre-oxygenation, where the main goals are to extend the duration of safe apnea and prevent hypoxemia during the apneic phase of intubation. Typically, it is carried out with tidal volume breathing, that is, with normal depth and rate of ventilation for at least 3 minutes. A face mask with reservoir is most frequently used oxygen source for pre-oxygenation in the emergency setting. In patients with adequate spontaneous ventilation, it is not necessary to squeeze the bag, but a tight seal must be achieved to deliver high FiO2. But in patients with inadequate spontaneous ventilation, pre-oxygenation should be undertaken using gentle positive pressure ventilation with the bag mask ventilation. Now, we have spoken about the rapid sequence intubation. Now, there is something called delayed sequence intubation, which is an alternative for rapid sequence intubation and to be used in patients with altered mental status, which prevents adequate pre-oxygenation. This technique temporarily separates administration of induction agents from that of the neuromuscular blockades so as to allow pre-intubation oxygenation and preparation. So, between the administration of induction agent and neuromuscular blockade, the patient is administered oxygen. And ketamine is currently the preferred induction agent because of its dissociative properties and established safety margins. But of course, there are a lot of other drugs too. Now, selecting the proper intubation method, such as rapid sequence or non-rapid sequence, is critical. And also, the intubator should consider not only the patient's condition, but also the environmental factors like the equipments which are available, the rescue devices that are available, the pharmacological agents, the drugs, staffing, etc. should be kept in mind. Now, these are the different drugs which are used during the emergency setting for airway management. Pre-medication should be given 2 to 3 minutes before intubation. Primarily, they include lignocaine and fentanyl. Lignocaine, the major indication being head injury, unknown mechanism of injury, which with elevated ICP, but there are potential adverse effects of cardiac arrest in patients with high degree of AV block. Fentanyl, again, in patients with elevated ICP to prevent further rise in ICP during intubation or in patients with cardiovascular disease for hemodynamic stability. Again, the potential adverse effect is that of respiratory depression and hypotension. Likewise, sedatives, etomidate, ketamine, midazolam, propofol, and thiopentol all have their indications and they all carry their potential adverse effects too. So, based upon the availability of these drugs, the intubator has to devise a practice so that the right drug can be used in the right patient. The next important step is to whether direct laryngoscopy or video laryngoscopy, if available, which one should be done. There are certain advantages of video laryngoscopy over direct laryngoscopy, like improved laryngeal view in patients with limited mouth opening, neck mobility, or difficult airway, faster time to achieve a successful intubation. It is a useful tool for teaching and training. There is lower risk at inducing local tissue trauma or damage. It permits others to share the view and also help facilitate intubation. Higher overall first pass success rate, especially in difficult airway, in cardiac arrest and intubations by less experienced providers, and also because it carries a lower risk of esophageal intubation. However, it is also has some disadvantages like the varial learning curve and multiple devices available before requiring different skills. It often gives an obscured view because of fogging, secretions, or blood in the airway. There is loss of depth perception and it is expensive. But no doubt, besides all those disadvantages, studies have reported the superiority of video laryngoscopy over direct laryngoscopy in the emergency room. And the VLUs is associated with a better laryngeal visualization, higher first pass success rate, shorter time to successful intubation, and a lower rate of intubation-related adverse events. If, however, we fail, then there are extraglottic devices which should be used during the emergency airway management. Mostly they're laryngeal masks and laryngeal tubes, which provide effective oxygenation and ventilation without entering the trachea. They can also be used as transitional device until definitive airway is established when intubation cannot be successfully achieved or the patient has a difficult airway. The next is the bougie. Bougie is also actually called the tracheal tube introducer, also known as bougie. It is used to facilitate intubation in patients with poor laryngoscopic views. When the bougie is used, it is generally used in combination with rapid sequence intubation and can also be used in conjunction with direct laryngoscopes, video laryngoscopes, or fiber optic intubation devices. However, we have to remember or note that this bougie is beneficial only when the epiglottis is visible and the vocal cords are not in all situations. Besides this management, which are common to all patients, there are certain specific issues in patients with trauma. All critically injured patients or traumatic patients should be treated as having cervical spine injury unless proven otherwise. Rapid sequence intubation is recommended for patients with trauma by clinical practice guidelines unless difficult laryngoscopy is anticipated. Etomidate, ketamine, propofol, midazolam are commonly used sedatives for patients with trauma. Propofol and benzodiazepines are used for hemodynamically stable patients with trauma with caution for their negative inotropic effects. Neurovascular blocker of choice is succinylcholine because of its rapid onset and short half-life. In patients with cardiac arrest, there are also some specific issues, but here the use of video laryngoscope in patients with cardiac arrest could improve the first pass success rate and minimize chest compression interruption. Clinical practice guidelines recommend intubation for patients with cardiac arrest should be carried out by skilled intubator. And naturally, the question comes that can be a skilled intubator or an experienced intubator, but the definition is not standardized. But for all practical purpose, more than 240 intubation experiences expected to achieve a 90% success rate without a prolonged chest compression interruption that is less than 10 seconds and complication is constitutes to identify someone as an expert intubator. So finally, my take-home messages would be that emergency airway management is one of the vital resuscitative procedures undertaken in the ICU, and everyone from the lowest to the highest in the hierarchy should be well versed in the various techniques in the algorithm. Always one should focus on the airway management algorithms as well as understand the importance of first pass success and systematic use of rescue intubation strategies. So a lot of times valuable time is saved by using the devices, and a lot of complications can be avoided or prevented by their early use. Systematic preparation and assessment of the difficult airways are the keys for achieving successful intubations. And although the use of video laryngoscopy is increasing, one needs to be cautious during video laryngoscopy, particularly in patients with trauma, where airway could be contaminated by blood and vomitus. And in that cases, the patient has a high risk of aspiration. So thank you very much.